My talk would be actually going in and out of what Prashant was actually mentioning. I would be getting into the details about examination, some important points as we go by, and also provide a little background to what we are talking about. The first thing that we look at, if you have a blunt injury patient, we have to actually have a common communication ground for which we have certain definitions in place about a closed globe or an open globe injuries. And all these things are actually related to the eye wall. So whatever we are talking about, everything is based on the eye wall. So in the closed globe injuries, we can have a contusion injury, we can have a lacerated or a lamellar laceration, we can have a superficial foreign body also sitting in the on the eye wall. Then you can also have lacerations of various degrees, could be from penetrating to perforating to almost about an intraocular foreign body. And you can have a frank rupture. Mind you, none of them are mutually exclusive. You can have all of them also in the same eye. What is very essential for all of us is to understand and talk in the same terminology. This talk is not involving that, but I would always recommend you to get into the BETS classification, which will tell you the detail on that. Now, if you look at a little background, the ocular trauma is a significant cause, and almost about 2.5 million injuries they occur annually in US. 40,000 cases have serious visual loss, and interestingly 75% of them are monocularly blind. But if you look at our own backyard, Arvind Eye study that was published provided a very interesting data that blunt injuries were major causes of trauma, almost about 60%. More in the males than in the females. And the lifetime prevalence of ocular trauma is higher than the glaucomas or the AMDs or the diabetic retinopathies that we look at. Now, most of these blunt traumas, the reason for the loss in vision is because of a primary mechanical damage of the vital structures, secondary complications like endophthalmitis or RD due to intraocular fibrosis, proliferations, contractures, etc. And the sequelae that happens to the blunt trauma, if you look at, go on from all these. Today we will be highlighting a couple of them, especially vitreous hemorrhage and management, retinal tears and management, choroidal rupture, macular holes, and scleral ruptures. Now, as Prashant did mention about a complete ophthalmic evaluation, one has to remember that an eye with no anterior damage may have a severe posterior injury, and a patient without hyphema or iritis may still have a large retinal tear, a choroidal rupture, or a blowout fracture. So with this background, let's look at individual vitreous hemorrhage, although I won't go much in detail. Vitreous hemorrhage, indirect ophthalmoscopy, sometimes you might not be able to see much of the thing, so you might need a backup with a B-scan ultrasound. And that's where we look for status of the vitreous posterior hyaloid phase. We look at the retina, whether it's in place or has been shifted out, or if you can identify a few tears. Now, important from the management point of view is to assume that a retinal break is present until proved otherwise. I think this is a big take-home message. And in case we are waiting and watching, then one of the reasons for which you might have a low vision after the hemorrhage has absorbed is because of a macular involvement or a choroidal rupture involving the macula, a traumatic maculopathy, could be a retinal detachment, or you could have a commotio retinae in the early stages. Now, the commotio retinae typically involves only the outer retinal layers and most commonly is seen in the posterior pole. I won't go into the mechanisms of that one, but it is important to say that you might get an initial vision loss of almost about 2200, but over time, in a month's time, the prognosis improves and the condition usually clears in about 3 to 4 weeks. However, the visual recovery could be limited if there is an associated macular pigment epitheliopathy, especially in the ellipsoid layer, choroidal ruptures, and a macular hole formation. Interestingly, there is no acute treatment in these cases. Now, if you look at the choroidal rupture, we are all aware about the mechanics of how the rupture occurs. And so most of these ruptures are because the brush membrane, which has little elasticity, may tear along with the overlying and the underlying structures, RPE and the choriocapillaries. So there could be an associated adjacent hemorrhage. And these ruptures may be single or multiple, and usually they are circumferential or concentric to the optic discs. And the rupture can extend through the central macular area. In post-traumatic macular holes, because the fovea is extremely thin, there could be a full thickness macular hole by either a contusion necrosis or a vitreous traction. One other condition is retinitis clopiteria, although it's very, very rare. I think it doesn't require more than that mention. Now, one very important thing is that in cases of clopiteria, chances of secondary retinal detachments are not there because you already have a fibrosis which is involving all the structures. This is the most important thing. Then you have the scleral rupture, and most common locations for a scleral rupture are the limbus and parallel to and under the insertions of the rectus muscles. Now, to repair these structures, we do it immediately. We need to do it from anterior to posterior. And the important thing for your assistant is actually to always have a cyclodialysis spatula who keeps on pressing the structures towards the inside so that as you go by in a zipping technique, you can close the wound. I think this is a very important feature that has to be looked at. Now, we are all aware of the diagnostic signs of a ruptured globe. Importantly, boggy conjunctiva chemosis with hemorrhage, decreased ocular reductions, deep AC, and it could be also a peaked pupil which can be pointing towards the rupture. There could be severe vitreous hemorrhage, and most of the times the intraocular pressures are lower. Now, traumatic breaks, if we look at, they could be either frank retinal breaks or a dialysis. And fibrocellular proliferation occurring later at the site of an injury may cause a tractional on the interface, or it can also lead to a retinal detachment. Now, most of these breaks occur because of direct contusive injury to the globe, and this could either be a coup lesion wherein you have adjacent to the point of trauma, or you can have it 180 degrees opposite to the point of trauma. Now, this is the only thing that we would look at, that the rapid compression of the eye results in severe traction at the vitreous base that may cause retinal breaks or a dialysis. If you find breaks, then they are most often seen either in the inferotemporal sector or the superionasal quadrant in this order. And contusion injuries may also cause what we call as a large equatorial breaks. Now, dialysis is also one of the other associated ones as they go anterior, and this can happen either at the anterior edge of the vitreous base, from where you can have even a small one like just involving one oral bay, or it could be almost about 90 degrees or a little more. So, dialysis are usually located at the posterior border of the vitreous base, but you can also see them in the anterior border. To identify that clinically, it's like a hammock. It's held at two places, and the vitreous just comes in forward, and you can see that very easily. So this is how you see as the avulsion of the vitreous base, which looks like a hammock, and then you can very nicely see the separation at the edge of the retina, the aura. Less common types of breaks that you see in these cases are the horseshoe tears or the operculated ones. Now, I thought it's proper because most of the injuries occur in young, so there are certain unique features in them. They rarely develop an acute rhegmatogenous RD because the vitreous has not yet undergone the liquefaction. So, since the vitreous provides an internal tamponade to the retina, in spite of the retinal tears or the dialysis, so you might have a later stage, shallow kind of a retinal separation that you will be seeing. And it's only over time when the vitreous liquefies over that the liquid now misdirects and then starts separating the retina. Now, clinical presentation of the retinal detachment ranges from about 12% of RD immediately to almost about 80% within about the next 24 months. Now, these traumatic retinal detachments in the young patients so usually present as a chronic RD with having multiple demarcation lines, subretinal deposits, and sometimes intraretinal cysts also. Optic disc avulsion, I think this is best to be seen on the ultrasound, where you can actually find a tract that is leading to the optic nerve of vitreous, hyperecho-vitreous, and that can be very nicely seen only on the B scan. Then you also have this compression injuries like the Purtscher Retinopathy. I think this we will not be talking. Thank you, and I think we can start with managing the vitreous hemorrhage.